Hey guys, it's Nurse Mike here with SimpleNursing.com. Today we're walking through blood transfusion procedures. We're talking safety steps, nursing tips, and NCLEX essentials. And as always, for my Simple Nursing members, please log into your membership site and grab this transfusion study guide. It'll definitely help you on your exams. All right, let's get into it.
Now we have three types. PRBCs are packed red blood cells. This is whole blood and must be given within 4 hours max after taken out of the refrigerator. And PLT, or our platelets, to help with clotting. This must be given within 30 minutes after being taken from the fridge. And FFP, our fresh frozen plasma, or basically our clotting factors, to ensure clients don't bleed out. These must be given within 60 minutes. Now, starting with PRBC, this is given for low H&H, that hemoglobin and hematocrit. The key numbers to know for exams is a hemoglobin less than 7 sends the patient to heaven. So write that down. This is a medical emergency. The NCLEX loves to test on this number. Now, a hemoglobin of 8 to 11, you must report this to the HCP and surgeon if before surgery. And as just mentioned, a hemoglobin less than 7 sends the patient to heaven. This client needs an immediate blood transfusion or will die from shock. Remember, shock is that severely low blood pressure and low perfusion, that low oxygen. So the top signs and symptoms to know for shock is number 1, pale skin, also called pallor or even dusky skin signs. Number 2 is cold and clammy skin. And number 3 is fatigue and weakness from the lack of perfusion. Now, this low blood count can result from blood loss, like during a trauma, like a car accident, and blood loss from a surgery, or even simply anemia, where total blood cell count is low. So Hesse mentions, a child involved in a motor vehicle accident has a thready pulse, decreased blood pressure, rapid respirations, and clammy skin with pallor. The client is not responding to the second fluid bolus. Which treatment would the nurse anticipate administering to ensure the safety of the client? And the answer is red blood cells, or PRBC, packed red blood cells. Now, the second question, the nurse is caring for a patient with a hemoglobin of 8 and a hematocrit of 35%, who is receiving an infusion of 1 unit of packed red blood cells. The nurse anticipates which result on the patient's next lab work, a hemoglobin of 9 and a hematocrit of 38. Yes, we'll actually break down the key numbers here in a moment, but just know that 1 unit of PRBCs will increase the hemoglobin by 1. Now, in terms of platelets, these are the little proteins inside the blood which help the blood to clot and prevent the severe bleeding. So these are given to clients with low platelets. Now, the NCLEX key numbers to know is anything less than 150,000 is thrombocytopenia, basically meaning severely low platelets. Now, anything less than 50,000 is very risky and very deadly. Clients can bleed out with the slightest paper cut or even bruise. So write down these key numbers and memorize them. They are need to knows for the NCLEX. Low platelet count typically results from cancers and certain types of anemias. Now, for FFP, our fresh frozen plasma, these are our clotting factors. It's kind of like the glue helping to stick all the platelets together in order to form a clot. Both are needed to stop the bleeding. Now, these are given to clients with low clotting factors, like clients with hemophilia, or even those with liver failure like cirrhosis, since the liver helps to make clotting factors. So it's important to know the difference between low platelets versus low clotting factors, since giving a bunch of platelets to a client in hemophilia will actually not do anything if they lack the glue of the clotting factors to hold those platelets together. Get a full breakdown of what you need to pass the NCLEX with our NCLEX Review lecture series and live cram sessions, led by myself and industry experts. Now, switching gears to transfusion reactions, these are the most tested. Remember, exams and the NCLEX love to focus on patient safety. So the most deadly complications are the most tested complications. Make sure to pull out this study guide for this section so you can follow the key points. Now, for any type of transfusion reaction, you must know these priority interventions. So write these down. Number 1 is slow or stop the infusion. Number 2 is to flush the body with normal saline. So the key terms is using new tubing, we give 0.9% sodium chloride, that normal saline. And number 3 is we report to the HCP immediately. And number 4 is we assess the vital signs and take a urine specimen. This is done to check for hemolyzed RBCs. I would write that one down. Big NCLEX tip. This means that the blood cells have lysed, or basically ruptured, releasing its contents into the blood, mainly potassium, causing high potassium hyperkalemia over 5.0. So just think, potassium is priority since it pumps the heart muscles. So we'll see peak T waves on the ECG monitor. Huge NCLEX tip. We have to put these clients on the ECG monitor. So ATI mentions the ordered response for a reaction to blood transfusion. Number 1 is stop the transfusion. Number 2, hang new IV infusion set. Number 3 is start 0.9% sodium chloride infusion, that normal saline. Number 4 is call the HCP. Number 5, assess the blood pressure, heart rate, and respiratory rate, the vital signs. And number 6 is obtain blood and urine specimen. Remember, that is done to check for hemolyzed RBCs. Now for the 4 types of reactions that you must know, starting with febrile reaction. This is a mild allergic reaction. We see flushing and redness and even itching. So again, it's a mild reaction as something new being introduced into the body. So we typically give acetaminophen, that Tylenol, and Benadryl before starting an infusion. Now A is for anaphylactic reaction. We see wheezing, hives, and hypotension, that low blood pressure. This is a more severe type of allergic reaction. And C is for circulatory overload. The signs and symptoms include lung crackles, restlessness, dark urine, shortness of breath and dyspnea, and even JVD, that jugular vein distension. This means that we're giving way too much fluid into the body at one time. We have a huge risk for heart failure. So just think HF for heart failure, HF for heavy fluid. We're giving too much at one time. So the big action, write this down, is to slow the infusion to 4 hours max. Big NCLEX tip. And we wait at least 2 hours between infusions, just so that we don't overload the body with fluid. Now the last thing we do is we give hope. So H for head of the bed is elevated. Sit that patient up with any type of circulatory overload. Next, we can give oxygen. P is for pushing diuretics ending in "ide," like furosemide. These help to drain the body from excess fluid. So just think they end in "ide," so they make the body dried. And E is to end all IV fluids. Remember, this client is in circulatory overload, so we don't want to give any more fluids and further overload the body. So ATI mentions difficulty breathing and crackles after administering PRBCs. The priority actions. Select all that apply. Administer furosemide, 40 milligrams IV push. Elevate the head of the bed to at least 45 degrees. Monitor for hypertension, tachycardia, tachypnea, and hypoxia. And notify the HCP. Yes, so just remember our acronym HOPE. And Kaplan mentions, the nurse is caring for a patient who's receiving a blood transfusion. The client begins to exhibit dyspnea, crackles in the lung bases, and becomes restless. Which action should the nurse anticipate? Slow the infusion rate. Yes, we can slow the infusion to a maximum of 4 hours. Now H is for hemolytic reaction. This means that blood cells have lysed, or basically ruptured, releasing all its content into the blood, mainly potassium, as mentioned before. But other key signs here is hypotension, that low blood pressure, lower back pain, that's a huge key term that loves to show up on exams for a hemolytic reaction, as well as fever, tachycardia, that fast heart rate, and a big NCLEX tip, as mentioned before, is urine specimen. We take the urine specimen to check for hemolyzed RBCs. So Kaplan mentions, which of the following indicates a hemolytic reaction? Low back pain and apprehension. The key term here is low back pain that indicates a hemolytic reaction. So please just know that key term.
Looking for more tips and strategies for questions like the ones we just covered? Well, our Simple Nursing membership includes exit prep lectures and thousands of questions across all nursing school and NCLEX topics.
Now for the 5 steps of a transfusion. Before we give a transfusion, we want to do 3 critical things, so write them down. Number 1 is 2 RNs must verify the blood order. So we have to check the name and the blood product. So with the blood product, we have to check the blood type and the Rh factor. For example, type A that is positive or negative. Second is we check the vital signs before and every 15 minutes for the first hour. We're looking for a reaction. And number 3 is PrEP, an 18-gauge IV catheter and 2 lines of tubing. 1 blood tubing with a filter and the second with 0.9% sodium chloride or normal saline. Now it has to be only normal saline, no LR and no dextrose. Only normal saline that is 0.9% sodium chloride. Now during the infusion, number 4, is we stay at the bedside for the first 15 minutes. Again, we're looking for a reaction, so we want to slow or stop the infusion depending on which type of reaction. Now after the infusion, step number 5, is we give 0.9% sodium chloride, that normal saline. This is done to kind of flush the body and add more fluids. Now Hesse mentions safe administration of PRBCs. Select all that apply. Number 1, we're priming the tubing with 0.9% sodium chloride, that normal saline. Number 2, obtain and document that full set of vital signs. Number 3, check the name and blood product with a second nurse. Number 4, administer 0.9% sodium chloride after the infusion. And number 5, monitor for signs and symptoms of a transfusion reaction, like fluid volume overload. Now the second question, a nurse is preparing for a transfusion of a unit of blood to a patient with anemia. The nurse knows which intervention is most important to prevent a transfusion reaction, double checking the blood product's type for compatibility with the patient's blood type. Now Kaplan mentions, the nurse is preparing to administer a blood transfusion to a client who has anemia. Which action should the nurse take first? Check for the type and number of units of blood to administer. Yes, always check the type of blood. And a nurse is preparing to administer a unit of PRBCs to a client. Which action should the nurse take? Remain with the client for the first 15 minutes. Yes, we always remain with the client to check for a reaction. Now Hesse mentions about a platelet transfusion. Select all that apply. Do not use a standard IV infusion set. And use a special set with a small filter and shorter tubing. These were the only key points only mentioned by Hesse about the administration of platelets. So I wouldn't really focus on it too much. Now another smaller topic is autologous transfusion. This is a collection of blood from a single patient that is retransfused back into that same patient when needed. Typically done for clients with particular religious views, like Jehovah's Witnesses, who cannot have other people's blood transfused into their body. Now Hesse mentions, the nurse is teaching about an autologous transfusion of blood to a group of student nurses. Which statements should the nurse include in the teaching plan? Select all that apply. Blood is stored in frozen conditions. Blood is stored for as long as 3 years. And blood may not be rejected by the patient's immune system, since the blood being administered is the patient's own blood. Be sure to have this study guide handy for this section, so you can follow the content and make this knowledge actually stick. Now for blood types and Rh factors. The main blood types are A, B, AB, and O. And Rh factors are the positive and negative antibodies on the blood surface. Now before you get super confused with all the crossing and matching between A's, B's, AB, and O's, and start ripping your hair out and reconsidering your life in nursing school, let's make this super simple. The NCLEX and your nursing exams mostly test on this. Universal donor is O blood. So just think O-type blood can be given to everyone. And universal receiver is AB. They can receive blood from everyone. So the memory trick, just think O is the universal donor. And for AB, think of six-pack abs. Everyone wants abs. So think universal receiver is AB for abs. Now Hesse mentions, a nurse is caring for a patient with type AB blood who requires a blood transfusion. However, the blood bank sends up type A. Which action should the nurse take first? Infuse the blood according to the agency protocol. Yes, AB is the universal receiver. They can receive blood from everyone. So come one, come all blood is welcomed here. So just think abs can receive any type of blood. Now the second question, a patient with anemia states I'm a universal donor. The patient has which type of blood? Type O. Remember, O is the universal donor. Now switching gears to Rh factors, the antibodies. These are the positive and negative antibodies on the blood surface. Now an indirect Coombs test is done to see if the blood is positive or if the blood is negative, and to make sure we can give and receive blood. So Saunders mentions, a client is donating blood. The nurse tells the client that an indirect Coombs test will be performed on the blood. The client asks the nurse about the purpose of the test. Which response should the nurse provide the client? The test detects circulating antibodies against the RBCs, the red blood cells. Now a little side note here for pregnant clients. For these Rh factors, RhoGAM is given to Rh negative pregnant clients with their second pregnancy to protect the baby, kind of like a shield. So write this down. RhoGAM is given to protect the baby from a deadly complication called HDN, Hemolytic disease of the newborn. Now this happens when we have an Rh negative mother and a Rh positive baby. The mom's negative antibodies can attack the baby's Rh positive and cause this deadly hemolytic reaction. So once again, the key point here is that we give RhoGAM to shield and protect the baby from this deadly reaction. Now pulling from our Simple Nursing NCLEX question bank, written by the people that actually wrote the NCLEX. Here are the top missed test questions. Question number 1. When preparing to administer a unit of packed red blood cells to a client with anemia, which nursing actions are appropriate? Select all that apply. So option number 1. Ensure that the patient has a functioning central venous access catheter. No, we can give blood transfusions through an 18-gauge peripheral line, not a central venous catheter. Now option 2 is correct. Have 2 licensed nurses verify the prescription. Yes, always have 2 RNs verify the prescription. Number 3 is also correct. Assess the patient's H&H, hemoglobin, and hematocrit. And option 4 is also correct. Auscultate the patient's heart and lung sounds. Now option 5 is incorrect. Prepare a bag of lactated ringers to administer with the blood. No, we only give normal saline. Remember, only normal saline, that 0.9% sodium chloride. Now, question number 2. Which is the priority nursing action for a patient who develops a high fever and tachycardia during the administration of the unit of packed red blood cells? So the key term here is a priority nursing action for high fever and tachycardia. So we must stop this infusion. So option D is the first priority action. Remember, we stop any infusion causing a reaction. And in this case, fever and tachycardia is a priority reaction. Now, question number 3, which is the most appropriate nursing intervention when preparing to administer synthetic erythropoietin to a patient with anemia from chronic renal disease? Now, if you haven't watched the erythropoietin video, then you might get this question wrong. But let's break this down anyways. Option 1, give the drug in the client's right deltoid muscle. No. Remember, no IM injections. We only give erythropoietin either IV or subcutaneous in the fatty tissue. Option 2, hold the drug for a hemoglobin less than 10. No, this is a big no-no. The indication for erythropoietin is to give the drug for a hemoglobin less than 10. So we definitely want to give it. We don't want to hold it here. Now, option 3, assess the patient's blood pressure prior to administration. Yes, this is the most important. Remember, erythropoietin can cause hypertension because it's increasing the total blood count within the vascular space. And option 4 is incorrect. Check the patient's urine output to ensure the output is at least 30 mLs per hour. Now, this question talks about the client in chronic renal disease. Basically, the renals are broken here, so they're not going to be excreting any urine. So the best option here is option 3. Always assess the blood pressure anytime you give erythropoietin.
Thanks for watching. Did you know you can unlock beautifully handcrafted study guides packed with key points and memory tricks from all our videos? Plus, you'll get access to over 1,200 exclusive videos not on YouTube, all neatly organized by nursing school topic, to make that complex nursing knowledge actually stick. You'll also gain thousands of practice questions written by current professors and actual NCLEX writers. So for access to all this and more, click right up here or visit simplenursing.com. And don't forget to subscribe to our YouTube channel. Happy studying, and we'll see you in the next videos.